Okay, look, I want to start and do this properly. So I will start by saying g'day, hiya, good morning and bonjour, and that should have most of us covered. So as some of you may know, you were subjected to workshops yesterday. We did it 7 times. I'm a little bit on the dry and crackly side. It is not champagne. I'm just going to stay lubricated as we get through this. So I just thought I'd let you know. This stint, I wanted to actually talk about you and I. This is about us now. We're not talking about patients, not talking about carers. We're going to talk about how health professionals deal with the fact that our patients have chronic and complex wounds. And we're talking about wounds, but in this presentation, you're not going to see a picture of a wound. I want to show you other pictures today. So let's make a start. Let's set the background as to what it is that we're dealing with, first and foremost. And you don't really need to look at the words on these slides, but please look at the photos because some of them I absolutely adore. And this is one of my favourite ones as we begin with. But the reality is in our practices, isn't it, that our population is ageing and their health needs are becoming more and more complex. And we've really arrived at a point in time where people are living older, but they're tending to live sick for a lot longer periods of time. And it's interesting that when we look at some of the research, they're saying up to 80% of elders, and in this case we're really talking about 75 years and older, have at least one chronic illness. I had one old dear gentleman who told me that his chronic illness was his wife. However, so that was bad luck for him or bad luck for her more likely. But we can see that venous leg ulcers is certainly a part of what is chronicity and complex kind of wounds. We're looking in Australia, and same here in the UK, around about 2% of our population seem to be subject to venous leg ulcers, and that percentage is probably a lot higher than that. And what we do know is that we're all spending plenty and plenty of money on caring for our health needs. So that's some of our background, but the other reality is that as time's going on and we look at a room like this where we've come to a conference and look at our average age, there's not too many young 20-year-olds or even young 30-year-olds in a group like this. So there seems to be less of us, but some of the data coming out suggests that those of us who are being trained and coming into healthcare may not, with the newer forms of university-based knowledge, necessarily have all of the skills to which they need to then come to be doing their wound management. And so I found this was interesting, that significant gaps in teaching wound management in undergraduate and postgraduate curricula have resulted in an unprepared workforce. So it's not just me saying that now, but Anne-Marie and her team have certainly coming up with that kind of insight. Non-health professionals, and this is something that is a little bit of a favourite topic of mine, but non-health professionals, certainly in Australia and I suspect here, are doing more and more of the hard yards with wound management. People who actually don't ever get to see a health professional very much at all, and sometimes not at all. So a lot of wound care is happening out there in our communities, but we actually may not really know the full extent of what is going on and what some of their issues and problems might be. We know we've got a number of carers in Australia. The 2009 census said that we had at least 2.6 million people registered as a carer, and yet carers aren't getting much in the way of education about wounds either, and yet they seem to be doing a lot of it. So that's an interesting fact as well. We're at a stage, it seems, in our professional lives where we're now a bit interested in patients' well-being and their quality of life, and the issues that surround that are impacting our thinking and our choices and what we choose to do in our care of them. We're all constrained by budgets and bureaucratic hoops. This is a picture of the accountant at the hospital where I work. We all have directives that we have to fall within with product formularies and so on. And one of the biggest deals that we have is that we all hear about cost of things, but there seems to be little knowledge or little sharing and certainly little training when it comes to actually working out what is actually clinical cost effectiveness. And that's a discussion again for another time, but by and by, with most health professionals caring for wounds, at least in our country, cost effectiveness is not something that's well understood. It is when you come to a conference like this, and then you have your industry representatives coming to see you at your workplace, a wonderful experience, but we do get to the point where at times we get up to our eyeballs, don't we, in the literature we should be reading, in the research findings that we should be somewhat aware of, and all of our product advertising. It is to the state where sometimes you feel a little bit inundated with all of the things that we've got to read and got to know about and got to be somewhat aware of. And so here is a poor gentleman up to his eyeballs in floods after Hurricane Katrina. So perhaps we've got this kind of problem as well with our own literature that we've got to try and get through. So how are we as clinicians coping when we're dealing with all of those issues as part of our background, but we're in the real world now having to try and care for patients, and these people have complex and difficult things to deal with? And so I thought that idea of the chook having been throttled is probably a fair enough view of where you might end up on a Friday afternoon ready to go home and collapse. So what did I do? Well, yes, Muggins here decided, having been informed by Ellie, to get my backside over here and do something useful. In those stressful few months of thinking, well, what could that possibly be, decided to do a little bit of a survey. And this survey has no great validity, no great reliability measures. It's scientifically possibly exceedingly unsound, which is why the only person who possibly approved my survey was Baldrick himself. However, who is involved in the survey? Well, I decided to ask some hospital-based nurses. They were in the facility that I worked in, a 600-bed hospital. I asked them to be involved in the survey. So that is within the northern area of Sydney, so that's a fairly large, decent institution that was involved to participate. But then I wanted community nurses, practice nurses and general practitioners to be involved, and there was a really good broad cross-section as to those who were rural-based and those who were city-based. So that's the group that I've asked my questions of, and we'll now see their responses. So as I say, this is only an insight, it's only a little bit of a grab. And if there's any interest to follow this up more formally, we might do that later on. So one of the questions was, how often were problematic wounds accompanied by a definitive diagnosis? What we've done is with those from hospital, community, practice and GP, everybody's got their own colour, so you can begin to see some of their responses. But I've condensed that a bit so that when we do see how many people with problematic wounds did receive a definitive diagnosis, it actually works out a lot of people didn't really get a definitive diagnosis for their wound. We didn't necessarily know why their wound was there, we just knew it was there, which means it was easy to treat symptoms, but not necessarily easy to treat the cause, particularly if we didn't really know what the cause was. How often did the patient have a clear understanding of their wound and the reasons why their wound might be chronic? Again, you can see the spread, but if we condense that, we can see that most patients had no idea why their wound was being a pain in the bum to them and still carrying on weeks, months or even years down the track. How often were the patients actively involved in setting goals and in planning their care? Well, a reasonable cross-section there, a bit more encouraging because it looks like we've got a bit of a balance where, okay, a lot of people were involved, but then roughly half were actually not that involved either. How did you feel? In other words, how did the clinician feel about their capacity to deliver wound care to patients with chronic wounds? And we can see that some felt confident, a lot felt pretty okay about dealing with these kind of wounds if they had a bit of help or guidance, but there were a small number who found the whole process quite overwhelming. We asked that when they, the clinicians, were about to see a patient who was revisiting with a long-term or problematic wound, how did they feel? A number felt confident about things. Others felt, oh, I couldn't really care whether I see them or not. I'm kind of a little bit over it. But there were a number that felt anxious. And it was with this question we realised that there is perhaps an anxiety undertone when people are coming in with chronic and difficult wounds. And I just thought, let's explore that a fraction more. When we broke that down a bit to do this kind of a graph, we actually found those groups who seemed to be reporting anxiety about dealing with chronic long-term wounds as coming predominantly from the general practitioners themselves and the practice nurses that worked with them. Those worked in community and hospital did report some elements of anxiety, but not nearly to the extent that the general practitioners and their staff did. Interesting, and again I can only say that remember Baldrick approved this, no one else, so this is just really giving some observation. Now, we decided to also ask how easily could these people obtain expert help if they feel that they needed help. Now, a number felt that they could easily, but the majority of those who did feel that way were based within an acute care or a hospital environment. As we come down to those experiencing more difficulty, it was actually the GPs who felt that they experienced more difficulty in accessing expertise with a problem or chronic wound. And you can see when we show that actually the difficulty in getting help was experienced by a large number, but the GPs really come out there as saying, I'd love someone to help me out, but I don't really have that kind of access. And when we overlay their ability to get help and their anxiety scores, there was, as you would expect, a correlation there, and those who were experiencing the most anxiety seemed to be those less likely to have help with caring for their patients. Now, none of that's necessarily a surprise to any of you, I'm sure. But what I want to do is I want to actually share with you what they said. Graphs are fine, they're cool and groovy, but I like these pictures better, and I like what some of these people actually had to say. And we'll start with a general practitioner who said that whenever I have to treat a wound that is complex, I just panic. So I thought, well, maybe it looks a bit like that. But yes, panic was the word that particular GP used. One of the hospital nurses said that I just get frustrated with chronic wounds when I can't get them healed. That is almost an accurate picture of what that staff member looked like. Another one of the hospital nurses says, I am much more confident caring for a patient with a chronic wound when I can consult with others, medical staff or our wound nurse consultant. And yes, that's about what he looked like after he made that statement too. Coming from another hospital nurse, the patients I see with chronic wounds seem to blame the health professional for not fixing their wound, which is hard to accept when they do not understand the factors impacting upon wound healing. It's interesting that this was a comment that was the first one that started to feel this sense of blame for something not going right or getting better. People feeling that they had this responsibility if things were not going well. I get so upset for my patients with chronic wounds as they are so often disheartened. And that does happen to us, don't we? When one of the things that we have a privilege of doing when we go with a patient who's got a problematic or chronic long-term wound is we share that journey with them. And this is one of the things that can be comforting to them. It can be a challenge to ourselves, but invariably there is a shared journey and there is an emotional element to it. So I can really understand why somebody might feel this degree of upset. It's nice if that degree of upset becomes, rather than disabling, perhaps somewhat motivating. But I do meet a number of clinicians, and particularly those in community settings, where they can feel this degree of disheartenment as being quite immobilising. Look at these little groovers doing their CPR. Isn't that just fantastic? Not sure I'd volunteer them to work on me when I needed it, but at least their intentions were great. The practice nurse says that the doctors are available to review wounds, but are not always familiar with the best dressings. Now, none of you can relate to that, I realise, but however. Other nurses in the practice are a good source of advice when available, but sometimes I am there on my own. And again, it's this capacity for some degree of isolation when you're needing to make decisions and have things happen because of your involvement with the patient. But isolation is a problem. Practice nurse says that confidence depends on the cooperation of patients, carers, GPs, specialists and treating nurses. If there is a lack of compliance or cooperation, the situation becomes anxiety-ridden. And I like the idea of what we're seeing here with our Blackadder crew. Compliance might be an issue, cooperation might be an issue, but you can see the anxiety already starting to rise to the surface. Oh, keep on going this way. George W., one of my absolute favourite people for any kind of conference when you want a decent picture of anything that could possibly go wrong. He's our man. I don't know what to do or to use if the previous treatment hasn't worked. And I'm sure that's been true of every conflict he has authorised, as well as what any practice nurse might suggest. Doc Martin we love. He's a favourite in Oz, and the new episodes that are coming out we're greatly looking forward to. I was very disappointed, having been in Cornwall recently, I didn't get to meet him by hand and shake his hand. A tragedy to have come all this way and not to have done that. But when talking to patients about their wounds, the explanations are often above them in medical language, which is perhaps one of the reasons why our patients don't get involved in setting their goals and looking at ways in which they might like their care directed. Maybe they don't get the opportunity or don't really understand what it is they're being told. I'm happy to start things off. This is a general practitioner talking, but if there is a problem with something, sometimes I need to ask what to do next. Fine if there's help there, but this now becomes a real issue if that help is not there to support that GP. Another GP has said that when I am confronted by a patient with a complex wound, I am not necessarily hopeful. And doesn't Lucy look not necessarily hopeful? And then, well, this reminds me of Ellie. That's a picture of Ellie in her slightly different days, maybe about 5-10 years ago. I always feel things are under control when I have a tissue viability nurse working alongside me. And that is interesting because I do think of Ellie when I saw this community nurse make that response, because I actually think this is where the Leg Club under Ellie's guidance has been heading for some time. So let's look at what these issues are. Now, this is not my grandson, but it looks like him at times. But I love that look of inquisition and, are you serious? So yes, we are serious. So what are the issues that have come up from this wee little survey, and what does it all mean and where is it heading to? It does seem to be that a lot of people with chronic wounds actually do not have a diagnosis as to why that wound is there. I've always thought that this is possibly not acceptable. I mean, if anyone here had a breast lump, just to refer to that as a lump and go on and deal with it is not acceptable. To have a leg wound which persists for 3, 5, 6 months and just to call it a leg ulcer is perhaps equally not very acceptable. But I think our patients have a right to a diagnosis. The fact that our patients have a poor understanding of their wound and the reasons for chronicity is something that we perhaps could be addressing better, and also there being involvement in the setting of goals where we can and should be working together. Most of the clinicians said that they are okay dealing with wounds, particularly if they had access to a bit of guidance. And those who were not working within the acute care sector, at least in Oz, were finding that they had difficulty in getting access to expertise, and that of course was causing them problems and anxiety it seems is a significant issue for those caring for people with chronic wounds, and particularly amongst our general practitioner community. So, before I show you that, having now given you all of this information, well, what happens next? Do I have any answers? And I would have to look at you honestly, each of you in the eye, and say, I have no answers whatsoever. However, from a befuddled mind between my ears, I have had a few thoughts. And I wrote them down in the 20 seconds that I had them, and here they are. I have a friend of mine who I see once a week, and we've been playing tennis together every Sunday from 7 a.m. to 11 a.m. for the last about 24 years. I never see him any other time during the week, but only then, as we go to our Church of the Holy Court and have our religious experience. It so happens that he teaches Tai Chi, and he has taught me a lot about what it is to have this aspect of mindfulness, this capacity to be in the moment so that you are totally focused with where you are, what you're doing, and what's going on. You know, in this day of the wonderful desire and acceptableness of multitasking, it's actually very easy for our thoughts and processes to be scattered, which is why we can look, but we do not see. You can hear, but you do not listen, which is why you've just had that handshake with someone you've just been introduced to, and then got no idea what his name was 5 seconds later. So we are very used to the absence of mindfulness, but to actually practice the skill of being in the moment is a very difficult thing to do and takes lots of practice. Sometimes it needs motivation. A really good group who do this well are combat fighter pilots. They're very much in the moment when you've got a missile firing along about to hit you in the backside. Likewise, our elite sportsmen are very in the moment. I've heard an interview once with Roger Federer, and he was saying that every point he plays is only done one shot at a time. He only sees, he only feels, he only thinks about that one shot at a time. So that skill of mindfulness is a potent skill, but it is the beginning then of where we travel, because with that skill of mindfulness, we do need a framework for thinking. If we are going to be in the moment to help our patient, well, what is it that we then think about? What is the process that we want to engage, and how do we do it? We're not going to go through Heidi and time or damp, any of those mnemonics, that's for another time, but we do have frameworks which are available, and it's worthwhile that we become familiar with them, we practice them, we use them. I had to show you this picture because I've always loved Peter Sellers and his films, but it was this particular quote that went with that picture so well, which I feel I can relate to most immensely. If confusion is the first step to knowledge, I must be a genius. I can certainly attest to confusion. The act of mentorship is, I think, the point where I want all of this to end up. I mean, mentorship, we often thinking about someone with more experience who can advise and guide and direct us. But there are a number of ways that mentorship can be conducted. In this modern day and age, there is the thought that we can be using technology, of course, web-based technology, and that we use social media so that we can be in touch with one another. And probably this is where the idea that mentorship and networking link hand in hand together. You know, processes like LinkedIn, and I'm not a big fan of Facebook, but LinkedIn is fine and emailing is fine, but we can bounce and learn so much from each other. So having networks can certainly help. And then access to the web, the tremendous resources as far as what is available now when you need to be looking at specific things, and maybe even just something like the Heidi mnemonic. But the web is a great source. But it is a very good, quick means that I can get in touch with a dear friend like Sylvie. There have been times over the years she's been a tremendous support to me. She is part of my network, as is many others in this room, and I'm grateful for all of that. What we're then seeing with Michelle Gibb has been putting forward is these Train the Trainer workshops, often again support by social media and web-based initiatives. And these things are becoming useful indeed, and lots of people in this room will have had access to these kind of supportive aids. Somebody who I've spent a little bit of time with in recent years is Karen Innes-Walker. And she last year at a major conference on the Gold Coast in Australia presented the idea of what has been coming out of the Cooperative Wound Research Centre, and that is having the capacity to place expertise in GP clinics or wound clinics and have them work for a 6-month period, providing on-site mentorship to both GPs and to the nursing staff, but actually placing people who are themselves acknowledged wound professionals in these kind of settings. These are the results that Karen points towards having achieved. She has noticed that when there has been mentorship provided on-site, that there is improved capability and confidence of all the clinicians, most noticeably amongst the GPs. There is enhanced patient and treatment outcomes, particularly when these have been linked to diagnosis, and then they've been monitored, measured, assessed, and then those outcomes foreseen and then recorded. Improved patient understanding of their wounds. This is one of the big things that came out of Karen's work, was that patients, when they had a better understanding of what was happening to them, were far more engaged, far more motivated, and usually got results in much shorter time frames. And the big deal, which is why the GPs actually really love to get these folks involved, is that they found there were tremendous cost savings, not just in the use of products, but in faster periods to healing, and therefore reduced cost with treating chronic wounds over longer instances of time. So having shared all of this dribble with you over this last half hour, what strikes me and what really came through to me last night when we had the conference dinner is the model that the Leg Club gives to all of us. Karen has suggested that the Leg Club model may go well with the cooperative wounds clinic role of putting people into centres as sources of expertise and mentorship. But I'm very aware that with the Leg Club model, mentorship is happening all of the time at many levels in many different ways, between staff who work within those leg clubs, between patients who attend those leg clubs, and now what's becoming increasingly more exciting is the involvement of GPs in leg clubs and the activities therein. The Leg Club, I think, is a marvellous platform for mentorship, and as we confront our challenges both now and into the future, I think mentorship is a great resource. It is something that is perhaps currently underutilised. All of us need to be involved in it and aware of it and redoing it as well as being receptors of it. And I would encourage all of us to think that as we do move forward, that we owe a great debt of gratitude to Ellie that we've actually got a model or a pathway like this that we may actually all implement. Thank you for listening to my dribble, and there is one last slide which I hope sums that up. Thanks again.